Okay, can you see the slide?
Yes.
Okay, can you hear us okay?
Yep.
There were a couple of questions on this end before we get started. One was, will the students be able to see their results on their test?
Yeah, they should be able to already.
It gives the percentage, but not the questions.
Like
about
this.
it.
Yeah, the answers that we were.
Yes, after the test closes and everybody's taking it, because it's due tonight at midnight. It'll open up and you can see what you got for it or what you did for answers. So. Other questions?
Paulette, wasn't there a question?
That was your med math. If it was due today.
Oh, yeah, the med math worksheets. Are they due today?
Did I have them due today? I thought they were due next week.
Okay.
Well, that
I'll
would be
go with that.
awesome because then we're going over it.
Yeah, I thought they were due next week, so, yeah, we'll just make them due next week so that we can go over it and talk about it tonight, so.
Okay, perfect.
Yeah.
Okay, well, and you said you can hear me okay?
Yeah, they are due today and next week.
Yep.
Okay. So let's go ahead and get started then. Can you guys hear me okay? Okay. Along with taking on this new role as an advanced EMT comes not only some new skills, but also added responsibility. And part of that is to really understand the reason for, in particular, the reason for giving fluids and the risks and the benefits that are tied to that. Okay, so as an AEMT, you're going to add vascular access and fluids because that's part of the scope of practice for an advanced EMT. So this is just an introduction to fluids and electrolytes. And when we administer fluids, everything really sort of revolves around that whole concept of homeostasis. So who can sort of tell us what homeostasis means?
Chemicals to balance out your chemicals. Or what your body does to make everything right.
Okay, so your body's always striving to be normal, right? Keep everything at an equilibrium, right? And so the neat thing is that your body has some built-in compensatory mechanisms to make that all happen, right? Anything to add in Sparta? Are you good with that?
Yep.
Or I'm sorry, go ahead.
All good.
The goal is to really keep the fluids and the electrolytes and the acid base in balance at all times. That's our goal. So water is really the most abundant substance that you have in your body, and it accounts for about 60% of your body weight. It is distributed through various compartments in your body, and those compartments are separated by cell membranes. So who could tell us what those compartments are?
Intracellular. Someone said extracellular and intracellular here.
Yeah, very good. Yeah, and actually most of the water is intracellular. So if it's not intracellular, then it's going to be extracellular. And the extracellular fluid is either going to be in between the cells or it's going to be in the vascular space. So if you have a higher percentage of body fat, that would mean you would have a lower percentage of water. If you lose about 20% of your total body weight in fluids, that could be life-threatening. And a smaller amount of water loss in the elderly can really have a major impact on them. Men have a higher percentage of water than females do. All right, so let's talk a little bit about that distribution of fluid then. And let's talk about intracellular fluid in particular. So we said there's most of the fluid is inside the cell, so would be intracellular in the cell. And there are certain electrolytes that like to live inside the cell, and that would be potassium, magnesium, and phosphate, like to live inside the cell. And then we have extracellular fluid, and that would be outside of the cell. And so the electrolytes that live outside of the cell, or like to live outside of the cell, are sodium chloride and bicarb. So if the fluid is not in the cell and it's outside the cell, it's either going to be in between the cells or it's going to be in the vascular space, in the intravascular space. Transcellular essentially means everything else. So that would be things like urine, digestive secretion, cerebrospinal fluid, pleural fluid, pericardial fluid. And then the pediatric patient, babies have a large brain. They have a lot of skin surface or body surface area. They have more interstitial fluid, and they have a very high metabolic and respiratory rate. Okay? So they can lose fluids more readily than an adult patient can. They don't have a lot of reserve, and they have a very immature renal system. They're not good at conserving water. They're also very active. And if they're sick, if they have a fever, if they are vomiting, they have diarrhea, if they have a traumatic injury like a burn, all those things deplete the fluid volume in the pediatric patient. All right, so now that we've established where the fluid is, let's talk a little bit about how the fluid is regulated. Okay, so let's talk about osmosis. Okay, so osmosis is the movement of molecules. They pass through a semi-permeable membrane from a less concentrated solution into a more concentrated one. So the goal is really to equalize the fluid on either side of the membrane. That's the goal. It's a passive process. And the goal, again, is to maintain homeostasis. Osmolarity or osmolality refers to how concentrated a body fluid is. And that has a reflection on how hydrated someone is. Have you ever heard of someone say that, they had noticed that their patient had very concentrated urine and it appeared to be very dark in color, like an amber color instead of a straw-like color? And that's probably because they're dehydrated. So there's more solute than there is solvent. So osmolarity tells us how many solutes there are in body fluids. Osmolarity will increase with dehydration, and it'll decrease if somebody is overhydrated. So if a patient presents with nausea, vomiting, and diarrhea for 3 days, what would you expect their serum osmolarity to be? Hello?
Somebody down here said hi.
Hi, excellent. Yay. All right, osmotic pressure. All right, so there has to be a mechanism to keep all of your fluid, all right, in check in terms of where it's supposed to be, in a compartment that's supposed to be. So an osmotic pressure plays a role in that. You have something called plasma proteins. Albumin is actually the biggest plasma protein that you have. And it's really sort of like the glue that holds the fluid inside the vascular spaces. And if you don't have these plasma proteins, that fluid is just going to shift and it's going to third space, which means that fluid is going to sit in that interstitial space. If you have fluid sitting in interstitial spaces, what is that called? If it's not inside the cell and it's not in the vascular space and it's sitting between the cells, what is that really called? And what would you see on your patient that might lead you to believe? Pardon?
Edema?
Edema, yeah, exactly. So if a patient has a lot of edema, they are third spacing that fluid, right? Does that make sense? So these plasma proteins then, and this osmotic pressure really sort of pulls that fluid back in, right? So it doesn't go into the interstitial spaces, okay? It's gonna keep that fluid in the vascular space. So it's a pulling force. Okay. So diffusion, defined as movement of solutes from an area of higher concentration to an area of lower concentration in a solution or across a permeable membrane. Okay. This is a passive process also. So this is sort of like, I don't know, like in your room you're sitting in right now, if somebody was standing at the doorway and they sprayed some perfume in the doorway, right near the doorway, there would be a very high concentration of the perfume. And as it diffuses throughout the room, okay, it's going to be less and less concentrated. So that's an example of diffusion. And then there's this concept of filtration. So, which it literally means to filtrate. Okay. So there's a force inside the capillaries, and that's called hydrostatic pressure. This is the blood pressure or the force against the vessel wall that's created by the contraction of the heart. This hydrostatic pressure is a pushing force, kind of like a water through hose. So it's kind of like the heart pushing blood outward towards the body. It opposes onconic pressure or that hydrostatic pressure that we just talked about. Kind of like if you fill up a balloon with water and then you squeeze it, you're applying hydrostatic pressure to it. So the heart pumping represents hydrostatic pressure. It pushes the fluid or the water into the interstitial spaces at the ends of the arterial capillaries away from the heart. And osmotic pressure counteracts this to maintain homeostasis. And this oncotic pressure uses these plasma proteins to move the fluid back into the venous capillaries towards the heart, back into the vascular space. And then active transport requires energy. It's not a passive process. And the best example of this would be the sodium potassium pump. It takes energy. There's active transport to keep potassium inside the cell and sodium outside the cell. That's where they like to live. Okay. And it's maintained because the cells actively transport potassium from the interstitial spaces to the intercellular fluid. So the other part of this regulation of fluid and electrolytes is your master gland, which is called your hypothalamus. The hypothalamus, which is the master gland, signals another gland called the pituitary gland. And the role of the pituitary gland is to send out specific hormones. In this case, it signals the pituitary gland to secrete something called anti-diuretic hormone. There are receptors in the hypothalamus that detect fluid fluctuations. And if there's less fluid in the plasma, these receptors stimulate the release of anti-diuretic hormone. The goal is to retain more fluid. You also have baroreceptors in your aortic arch and in your carotid bodies, and they also watch blood pressure constantly. If there's an imbalance here of fluid, what do you think the first symptom would be that a patient would have in terms of your body's attempt to regulate fluid balance in your body? If your body perceived it was low on fluid. Thirst. Good. So if we look at patients who are altered, who are unconscious, who can't speak for themselves, they can't feel that need to take in fluid. So they're really sort of in a helpless state. And so that's the reason for us to be there to help them. Because if we don't, they're going to go into hypothermic shock and they're not going to do well. Now, there's another part of regulation here, and it actually involves the kidneys. Okay. So there's some additional hormones that are secreted by the kidneys. Okay. This hormone connection is called the renin-angiotensin-aldosterone system. Again, this is another attempt to maintain blood pressure and fluid balance. When your blood pressure drops for any reason, there are special cells in the kidney that detect a change here, and then they will release renin into the bloodstream. Angiotensin 1 is converted into angiotensin 2. And then this causes a change in the blood pressure. As soon as angiotensin 2 conversion takes place, this causes vasoconstriction, and that then will cause an increase in the blood pressure. It also stimulates the release of aldosterone. Aldosterone causes the kidneys to retain both salt and water. And again, the goal here is to increase the blood pressure. There's also another hormone. It's a cardiac hormone. It's called atrial natriuretic peptide, or ANP. This is released by the atrial muscle cells. And as the atria distend, this hormone is released. It's actually atrial distension and also sympathetic stimulation causes this hormone to be released. It's a counterbalance, because if this renin-angiotensin system 2 did not have a counterbalance, your blood pressure would be through the roof. So this hormone then balances it so your blood pressure doesn't get too high. Okay, that's what this AEMT is. So it's sort of like a long-term mechanism to maintain water balance and blood pressure. So this hormone here then kind of stimulates a decrease in the amount of aldosterone from the adrenal cortex. There's 3 types of intravenous fluids: colloids, blood products, and crystalloids. Colloids are commercial type blood products. They mimic blood products. They have big proteins, just like blood products do. Crystalloids are the primary fluids that we use out of the hospital setting. And they do contain electrolytes and water, but they don't have these large proteins in them. And they're classified by their tonicity in relation to the blood plasma. Isotonic fluids are the ones that you're going to most commonly carry as an advanced EMT. They have a tonicity that's very similar to your blood plasma. In a normal situation, if you're normally hydrated, they have very little impact in terms of fluid or electrolyte shifts. That's why they're a very good choice, because they're a fairly safe choice if you're treating patients who could potentially become hypovolemic or are hypovolemic. So isotonic fluids are good if you do have a hypotensive patient. It'll maintain fluids in the vascular space. You still need to watch for fluid overload though, especially if you're dealing with a patient, for example, that has congestive heart failure, that struggles with excessive fluid volume. So you do have to monitor the blood pressure. You do have to monitor for edema, peripheral edema, and also pulmonary edema. So would it concern you if you started an IV on a patient that was an isotonic solution? You should always check lung sounds before you start an IV. If the lung sounds were clear, and then you started some fluid boluses, and then you reassess the lung sounds and you noticed some crackles, would that concern you? Yeah, it should. Yeah. What would you do at that point?
Stop.
You probably want to consider the risk versus benefit of continuing fluids, you know, and what do your vital signs look like? And why you're giving the fluids to begin with. So isotonic solution, you know, can be used for blood loss replacement, you know, really until the patient can get blood products. You know, if a patient is a trauma patient and has lost a lot of blood volume, that means they're losing red blood cells. And if they're losing red blood cells, they need to have that replaced, because remember, oxygen travels around the body on the hemoglobin molecule attached to the red blood cells. So if you don't have that, you have no oxygenated blood going around. So if you just continue to give normal saline endlessly, all you're doing is diluting the blood. There is no oxygen. So at some point, you know, if you've given 3 liters of fluid, you need to start thinking about, you know, where's my next stop for blood products for this patient. Lactated ringers is also an isotonic solution. It contains electrolytes, sodium chloride, potassium. It also contains some lactate, which is a buffer. It's not as commonly used in the pre-hospital setting. It's probably used more so in the hospital setting, very common in a surgical suite. In hospital trauma patients, they'll use lactated ringers. If you have a trauma patient and you have cells that have been disrupted, what happens is you have potassium that leaks out of the cell. And so that's the reason for having the fluids that have the electrolytes added. But we don't routinely carry lactated ringers in the field. Then there's hypotonic fluids. Some examples here: half normal saline. Again, we don't carry. We don't routinely carry hypotonic solutions in the ambulance. Hypotonic solutions cause water to move into the cells. There is the risk of cells swelling and bursting. A hypotonic solution has less solute than inside the cell. So what will happen is that fluid then is going to be pulled into the cell, and it could potentially cause the cells to burst. And so it is not a routine fluid that we're going to use in the ambulance, and it would have to really be given in the controlled setting. There's really no fluids that you're going to carry that are going to be D5W is actually isotonic when it's in the bag, but when you actually give it for fluid resuscitation, it actually turns into a hypotonic state once you're running it, but that would be the only example. And then there's hypertonic solutions. Now you will carry some hypertonic solutions in the ambulance. For example, D50 is hypertonic, 10% dextrose is hypertonic, and you'll carry both of those in the ambulance. So hypertonic solutions have a higher amount of solute than inside the cell. So it's going to pull fluid, or it's going to pull fluid from the cell. It's actually going to shrink the cell or dehydrate the cell. So, and then this just sort of reiterates that, you know, fluid that fluid can be lost from the body, you know, it's not necessarily visibly seen as fluid loss, but it could be just displaced. You know, like someone could have adequate fluid volume, but it's not either in the cell or it's not in the vascular space. It's just sitting in the interstitial spaces. A good example of that would be a burn patient. Their fluid is sitting in between the cells. It's not where it's supposed to be. So the goal there is to shift fluid to where it's supposed to be. So again, the goal here is just homeostasis. The fluid needs to stay where it's supposed to be, either in the cell, outside the cell, in the vascular space, and not excessively in the interstitial spaces. So if we look at the comparison for these fluids then, isotonic solutions really cause very little movement. So there's an equal amount in terms of what's in the cell or what's in the vascular space. If you infuse somebody with a hypertonic solution, there's more solute in the solution than there is in the cell. So that is going to pull fluid from the cell into the vascular space, but there's the potential for dehydrating the cell. If you give somebody a hypotonic solution, there's less solute in that solution than there is in the cell. So it's going to cause fluid movement out of the veins, out of the vascular space. Any questions or clarification on intracellular, extracellular, hypertonic, hypotonic? Are we good? You're good. I guess everybody's good, Tim.
Yep.
I'll stop sharing.
So. You guys need a quick break or you want to keep moving? Good.
Keep going. Okay. They said keep going on this end.
Okay. So the next one we're going to go through is mathematics, right? Clinical math. Because a lot of what we're going to do, we're going to have to remember, hey, we're giving fluids, we're trying to calculate medications and stuff like that. So most of them aren't too hard, but when we start getting to doing drip rates, that can be a little bit harder to do, right? So have you guys all taken a chemistry class before? About 20 years ago, right? So this might be a little bit of a refresher on that chemistry and converting things from one thing to another. But a lot of what we're doing is because really when we give a medication, the hospital or the doc or our protocols will give us this is how many milligrams or of a medication that you want to give, right? So they give you a weight dose. kind of thing. Can you put solids into bodies? Right? Can we put, unless you're eating it like a pill, but can we put solids into our veins and stuff like that? No, we got to convert that to a liquid somehow. And usually that's putting it into a normal saline type thing to create that fluid. So then mathematics and converting that from those masses to a liquid is kind of what we're gonna do. So first we'll start off with kind of a funny, and this might be you at 3 o'clock in the morning trying to do math, right?
Percentage. I figure 75% to you, Panma, and 25% divided by.
Why is it not coming through the? Can you guys still hear us?
Yep.
Okay. Can you hear the sound here?
Between the 5 of us, Yida, Crowbar, myself, Tom, and the baby. That makes 5% for each one of us.
Billy, you're cheating yourself.
Let's try it.
Now it went away.
Percent to you, Panma, and 25% divided between the 5 of us, Yida, Crowbar, myself, Tom, and the baby. Percentage. I figure 75% to you, Panma, and 25% divided between the 5 of us, Yida, Crowbar, myself, Tom, and the baby. That makes 5% for each one of us.
Billy, you're cheating yourself. If there's 25% divided among the 5 of you, that's 14% apiece.
Oh, no, listen, Pa. I wouldn't cheat you. You know I wouldn't. Now, look here. I'll show you. Let me rub this out here. And now, 25 divided by 5 is 5. You see, 5 won't go into 2, will it? No. But 5 goes into 25 5 times, you see?
No, you're wrong, Billy. Now, I'm a pretty good mathematician. Now, 5 into 25, 5 won't go into 2, will it?
No.
But 5 goes into 5 once. Now, we didn't use the 2 before, so we bring it down here. Now, 5 into 20 goes 4 times. There you are. 5 into 25, 14.
No, look, Pa. Let me prove it to you now by multiplication. 5 times 5. 5 times 5 is 25.
Really, I'm surprised you're learning.
Huh?
I'm surprised that you're learning. Now I'll show you. 5 times 14 is 25. 5 times 4 is 20. 5 times 1 is 5. 25. That's it.
No, look, Ma. Look, you're wrong there because I'll prove it to you. We'll put down 5 14s here. 14. There. Now I'll prove to you by addition that 5 14s is not 25. 4, 8, 12, 16, 20.
21, 22, 23, 24, 25. There you are. Billy, I don't want to see you boys cheated.
I figure.
You like that? That's your 2 o'clock in the morning math, right? So let's make sure we're still recording here. So most of the drugs that you guys are going to get don't have too hard of calculations to give, but you still need to start thinking about adding or converting some of the stuff and getting that math and figure it out. So interpreting the drug order. When you're giving a med, usually you have some sort of drug order, whether or not it is given to you by the hospital or the doctor, your medical director, your protocols, but we have a drug order, right? What do we want to figure out every time we do any sort of medication? What are the rights? Right route, right dose, med, right patient. Okay. What else we got? Right documentation. Okay. So you want to make sure you have those 6 rights. Okay. Figure it out. So make sure you have the right drug name, concentration. Right. So when you look at a med, okay, about a vial of fluid, it's usually got a concentration on it. Okay. Like epinephrine. Okay. What is, you guys know what epinephrine is? The little vial of 1 to 1,000 epinephrine that we get. How much fluid is in it? 1 milliliter, right? And how much medication is in that milliliter? 1 milligram. So your concentration is 1 milligram per 1 ml. Okay, does that make sense? So every drug is a little bit different based on what you might have. Narcan is 2 milligrams in 2 ml in one form of it, whereas another form, it might be 0.4 milligrams in 1 ml. That's the Carpiject form. So you really want to make sure you pay attention to what type or what concentration of the med you have, because it might be different. And then, so you give the right dosage, right? So going back to epi, what's our standard adult dose of epinephrine? 0.3 milligrams, right? And it's 1 to 1, right? 1 milligram per 1 ml. So that makes it easy. It's 0.3 ml. Okay. So, and then as a kid, it would be 0.15, right? For the pediatric dose. Okay. One thing you want to make sure you look at is your syringe too, right? For that small of a ml, 0.15 ml, you should probably use the 1 cc syringe, right? It breaks it down. Because if you grab a 3 cc syringe, it's kind of hard to guesstimate 0.15, right? And you might be like, okay, 1.5. You want to make sure you get the right syringes so that you get the right dosages. Okay. Right route, because different meds can go to different locations. Okay. Epi is generally going to be IM or sub-Q. Okay. Narcan, though, can go where? Nasal, IM, IV, IO, sub-Q, pretty much anywhere, right? So, but it's the same, thankfully for Narcan, it's the same dose for that one, no matter where you go. Some drugs might be different depending on the route that you go. And then frequency, right? How often can you repeat it? So you want to look at those things. We try to use standard abbreviations, and we try to use the metric system in the medical world so that we can try to avoid any confusion. Placing a 0 before dosages is actually pretty, we get very complacent with that because like we were saying 0.3, 0.15 for, you want to say 0.3, right? Especially when you write it down, because if you don't put that there, somebody might think that that point might be like a dot on a paper, right? So you want to make sure you get that 0 point something so everybody knows and doesn't get confused. So only use standard abbreviations. We generally try to stick with what is standard across the board in the medical field. Kind of goes back to that whole talking on a radio. Do we use 10 codes anymore? No, we're not the police, right? Only they use that stuff. Leaving them, they are not supposed to use that stuff really right now anymore. So only to talk in plain language. Right? Same thing with this. right? If you're going to be abbreviating something, only use that standard abbreviation. If you don't understand what the order is, ask. Right? Ask, call medical direction, get clarification on it. So again, generally we use metrics, right? The metric system. Based on that 10 system, or multiples of 10, so it makes it pretty easy to calculate some of that stuff. Prefixes, right, for multiples or submultiples. Okay. So for mass, one, we talk about grams, right? That's kind of your standard. And then to make it smaller, we go to milligrams, okay? Divide by 1,000. And then you could divide by another 1,000, get micrograms, right? And then if you go the other way, it would be grams and then kilograms. And we generally do weight of patients in kilograms. So mass, is that gram? Volume, we talk about liters, right, or milliliters. Generally in the medical field, it's liters or milliliters that we're going to use. Generally don't go to the microliters because it's just a very small amount of fluid. And then length in the meter. So here's some standard equivalents. Okay? There might be a similar chart in your book that talks about standard equivalents and how to convert from one to the next, right? So like 1 gallon is 4 quarts or 3.785 liters type of thing. Just one of those standard things. Usually what we're going to use is we have to do something like that. You might grab your phone and do a conversion calculator or something like that if you don't know. Things that we will likely use is grams to milligrams or grams to micrograms or milligrams to micrograms, something like that. Liters to milliliters and then pounds to kilograms. You guys know what the conversion rate from pounds to kilograms is? So yeah, 1 pound is 2.2 kilograms, right? So just divide by 2.2. There's another way to do it, which is most people can't do in their head. It's multiplied by 0.45. A pound, 1 pound or 0.45 pounds equals 1 kilogram. Right? So it's the same thing, but just 1 pound or 1 kilogram. 1 pound is 2.2 kilograms.
That's yellow.
Did I say it backwards again? 1 kilogram is 2.2 pounds. Yeah, there you go. Yeah, so just remember that one. Okay. The middle of the night way of doing it. Okay. Take your pounds, divide by 2. Okay. And then what's 10% of that? Take 10% off. So if you had 22 pounds, divide by 2 is 10. Okay. Take 2.2 off of that. And you got 7.8 kilograms. And then 1 gram is 1,000 milligrams or 1 million micrograms. Okay. So to go from one to the next, you just divide by 1,000. Okay. One milliliter, if someone says 1 cc, that is equivalent to 1 milliliter. So someone might say, well, I have a 500 cc bag. Yeah, that's a 500 milliliter bag. So there you go. So 44 pounds, okay, divided by 2.2 gives you 20 kilograms. Okay. And then here's that middle of the morning, middle of the night. Okay. You go 44 divided by 2 gets 22, and then take off 2.2. That gets you 19.8. Gets you pretty close, right? Not perfect, but it's pretty close. So if we had 200 milligrams, how many micrograms would that be? Oh. 200,000. So when you want to look at the drug you get, you will really need to know that concentration that we talked about before. And a lot of that is done by cross multiplying and dividing. So, and a lot of the calculations that we do are weight based. So when it comes to giving fluid to a patient, the general term for giving fluid, with some minor differences to it, is you don't want to give any more than 20 milliliters per kilogram of like normal saline. Okay. That's kind of that general rule. Okay. So if you had a baby that was, we'll say 10 pounds, right? 10-pound baby, how much fluid are we going to give that patient? We're going to give that baby fluid. 100 mL. Pretty much, right? So divide by 2, get you 5, take off your 10%, you're still going to be about 5, a little less than 5. So 5, 10, 20, it'll be more actually. So 100 mL. Yep. You don't want to give any more than that to that size kid. Now, myself, being a little less than 100 kilograms, right? At 20 milliliters per kilogram, how much fluid could you give me without causing too much problem? 2 bags. Yeah, 2,000, right? 2,000 milliliters or 2 liters, right? So those are some of those things you want to kind of keep in mind, right? Everything is weight dosed to include your epinephrine. Right? Epinephrine will be like 0.01 milligrams per kilogram, right? Up to a certain dose, right? So up to your 0.3 or 0.5. So, or for a kid up to the 0.15. So everything is weight based. So you might have to calculate that out when it comes time to looking at a medication for a patient. So convert it to kilograms. We are not good, at least in the US, at estimating somebody's body weight. So kind of remember that. If you can, get the patient to tell you what they weigh. Otherwise, for kiddos, you might need to use your length-based resuscitation tape. Okay. What's another name for that? Your Bosley tape, right? Yeah. So, and those generally have a guesstimate of weight. Okay. So here's some different parts that you'll have to remember too with the fluid, right? Or an IV set. You've got your IV bag on the top, right? And then in here on your administration set, right? You're going to have at the top, there's going to be a fluid chamber, right? Then some tubing, your flow regulator. You might have 1 or 2 drug ports, right? That you can add meds to it or add another bag if needed, stuff like that. And then it would go down to your IV, right? And connect to the IV. When you're looking at this administration set, there's 2 different types. Okay? You've got your macro drip set and your micro drip set. Okay? Your macro drip set can come in multiple sizes, either 10 drops per milliliter, 15 drops per milliliter. I've even seen a 20 drops per milliliter out there, but most time what you're gonna see is 10 or 15. But those are macro drips, right? Generally what you're gonna give an adult if you're just giving fluids type of thing. Micro drips, okay, those are your 60 drop per milliliter sets. That's what you're gonna use for pediatrics and or giving certain medications. Right? If you need to give a specific dose, right, of a medication, the micro drip is going to be a lot more accurate at getting that. Macro drip is for giving lots of fluid quickly. Micro drip is for giving more precise measurements. Medications, which pediatrics is, you want to be more precise with that. So to get those drip calculations, you really want to know whether or not it's macro or micro and how many drops per milliliter it is. Okay? So you want to know how many drops it's needed to infuse 1 milliliter. Okay? And that's that 10, 15, or 60 that I was just telling you about. Another thing you need to know is time. Okay? How long do we want to put that? Do we want that medication to get into the patient? Okay. So you want to know how much time it's going to take to calculate this. And then there's either to keep open or keep vein open. Okay. They mean the exact same thing. Okay. Basically, we're turning it down as pretty much as slow as you can give fluid, with just giving enough just to keep fluid flowing through the IV so it doesn't clot up, right? So it's generally pretty slow, almost all the way closed, as long as a drop keeps going every 20, 30 seconds or so. Just keep it going, right? And you might need to go a little bit faster, but just keep some fluid moving over time. So setting the driplet, okay, you're going to adjust the flow to how many drips you want to do. Okay. So if once you calculate it out, you determine, hey, I need 100 drops per minute, okay, for this fluid. Okay. Easy way to do that is, okay, divide that by 4. So I need 25 drops in 15 seconds. And then you can look at your drip chamber and count 25 drops in the 15-second range, and that's how fast you want to go. Most of the time, okay, not all the time, but most of the time, as an advanced EMT, you're probably going to do wide open. So it's all the way open, flowing fluids, or to keep open, are the kind of two extremes that you'll do, or you might do somewhere in between based on what you want to give your patient. Okay. So you'll adjust that roller time to how fast you want that fluid to go. So we'll start off next with the desired dose, okay? And that is how much medication you want to give, right? That's the desired dose that we want to give our patient. Okay? And again, it's usually expressed in a weight, okay? And we have to convert it to a volume. Okay. Dosage on hand is what you have of the solution, right? And that's usually your concentration. Okay. So your epi would be your 1 milligram per 1 ml. That would be your dosage on hand. And then the volume on hand, the ml, right? So dosage on hand, 1 milligram, volume, 1 ml. Other things you might look to see is desired dose or dose ordered. That is what your protocols tell you to give, what your doctor is telling you to give. That's the dosage that we want to give that patient. Volume on hand, and then dose on hand, those abbreviations. So if we look here to calculating it, we already kind of talked about it, but this is more to see it. You want your desired dose, right? So if, for instance, epi, we want 0.3 milligrams. That goes right there. Okay. in the parentheses is the volume on hand. Okay. So we have 1 ml, right? And then our dosage on hand is 1 milligram. So by having milligrams up here and down here, those cancel out. And you're left with 0.3 times 1 divided by 1. So that gives you your 0.3 in milliliters, because that's what's left up here is milliliters. Okay. And then if you look at it another way, you do your desired dose times your concentration. Right? So this is what I was just saying. So you've got your 0.3 milligrams here. It's in a 1 milligram per 1 ml concentration. Those milligrams cancel out. We're left with just mLs. And then it's 0.3 times 1 divided by 1. Does that make sense for everybody? So that's the easy ones, right? Now, if we said we want to give 0.4 milligrams of Narcan, okay, and it comes in a 2 milligram per 2 mLs type of concentration, what would you give?
One, 4, and 2.
Right? See if I can get this to come up.
Just 0.4 mLs, right?
Yes. It would be 0.4 mLs. Okay. If you guys can see that. So you get 0.4 milligrams, right? 1. And then our ours on hand is 2 milligrams per 2 mLs. Okay. Your milligrams cancel out. You can actually cancel out your 2s, and you're left with just 0.4 milliliters. Right? And we're multiplying this. Does that make sense for everybody? I hope. Okay. Let's go back to. So now if we add a weight based in there, okay, what you're going to add in there is the weight, right, in kilograms. So you've got your desired dose multiplied by the weight and the volume on hand divided by your dosage on hand. Okay. Does that make sense? So if my patient is 44 pounds, again, we converted that over to kilograms, which is 20 kilograms. Okay. And we want to give 0.025 milligrams per kilogram of a medication. Okay. We're going to multiply that by 20 to get to what we want, which would be just milligrams then. Okay. So, and our dose on hand is 1 milligrams in 1 ml. So 0.025 milligrams times your kilograms, okay, over 1 ml, which they didn't put. It's 0.025 milligrams per kilogram here. So that cancels out that other kilogram. So if I write that here so everybody can see. We have 0.025 milligrams per kilogram. Okay. And we have 20 kilograms. Okay. And our thing was 1 milligram per 1 ml. Okay. You multiply that out. Milligrams cancel, kilograms cancel. Okay. And then it's just 0.025 times 20. Okay. Which would give you your med. Milliliters left. Which gets you 0.5. Still, did I lose anybody yet? Good. So then we add another step, right? So we want to get an infusion rate from that. And like I said, there's micro drip and macro drip sets. GTT is the abbreviation for drops. Means it's Latin for gute or drops. So in a micro drip, and I'll show you it when we start looking at them, the difference there, but there's a smaller little spot in there, a little tube in the micro drip set. So in that one, 60 drops equals 1 ml. Macro drip, 10 big drops equals 1 ml. There's a couple common ones. So with this one, you're going to add in there your drop factor, right? So we want a volume to be administered, right? So if we're going to give, say, 100 mLs over 30 minutes, okay, well, make it easier. 100 mLs over 10 minutes, okay, multiplied by your drops per milliliter, and we'll say 10 drop tubing. Okay, so 100 mLs, okay, times 10 gives you 1,000, right? 10 minutes times 1 ml gives you 10. 1,000 divided by 10 brings you back down to 100. So your drops per minute would be 100 drops per minute. Does that make sense? You guys see that, how I talked it through? So here's a different way. You have 1,000 ml normal saline hanging, and you want to administer 100 mLs an hour with 60 drop tubing. Okay. So if we take 100 mLs per 60 minutes, okay, multiplied by our 60 drops per ml, okay, the mLs are going to cancel out. Your 60s are going to cancel out. Okay, and you're left with 100 drops per minute. And then if you used 10 drop tubing, it'd be 100 times 10, 1,000 divided by 60 minutes, which would get you about 17 drops. So flow rates are more critical when it comes to pediatrics, or if you're giving specific medications that, for instance, in a hospital, if you're working in a hospital and they're giving different meds, that's more important for it that way. Because you don't want to over or underdose somebody. Okay. If you have the ability, use a calculator, right? Everybody carries a phone, right? Even in the back of the ambulance, most people have a phone on them. Okay? If you have a calculator, use it, right? Some services have tablets, right? Usually there's a calculator on there that you can use. So if you have the ability, use that. Because we're not all great at math, especially in the middle of the night or when we're tired. Questions?
It's gonna be online, so I can watch it.
And if you have questions, we will go over it, right? Because we've got whiteboards we can draw on. But so questions on medical math? It's usually simple math. It's just like simple multiplication and division. But once you have to get used to setting it up properly to getting to that easy math portion, right? So it's usually bigger numbers, like 1,000 divided by 60. So it's not necessarily something that's going to be easy to divide in my head, but it's usually numbers like that versus random things like the 0.025, right? That you might get occasionally. But setting it up in the correct order initially will help you calculate the correct dosages. So my best advice to that is take your time. When you're trying to calculate something, take your time. Right? Usually, if patient needs fluid, okay, we can give them, and they have a low blood pressure, let's give them a 250 bolus, right? We can turn it on, give them a bolus of fluid, make our calculation of how much we want to do. In that time, it takes that 250 to flow, right? And just keep reassessing. Right? As an advanced EMT, I can tell you there's not a ton of times that I've been in the back of the ambulance that I've had to sit down and calculate something out, right? It doesn't happen very often, but when it does, it's important. Okay? Especially when it comes to burns. That's one of the big ones because you don't want to give too much too fast. Trauma, usually, depending on how far you are from the hospital, you don't usually give too much too quickly for a trauma, but you could, right? So, and even when you're giving more than 250, you calculate out, hey, I want to give a whole liter, right? Because that's what my calculation says. Reassess in between, right? You hit 250, reassess, check the lung sounds, right? Why do we check lung sounds when we're giving fluids?
Make sure you're not causing edema.
Yeah, because one of those things that if we're giving too much fluid, one of the places we're going to hear it is in the lungs, right? If fluid's getting in the lungs, stop, right? Because that's too much fluid in the system right now if it's pouring into the lungs, right? You might see pedal edema types things also. So if you see that, generally we're not going to give any more after that. Okay. Questions? Any questions out there?
So,
No? Okay. So let's take 10 minutes at, like, on the computer here, it says it's 6:20, so, but we'll say 6:30, 6:35. Yeah, I think my real time says it's 6:35 or 6:25 right now. So 6:35 we'll be back and we'll go over, start talking about IVs. Okay.